Resolve to Save Lives and Jacobs have collaborated to develop a model for epidemic-ready, climate-resilient, and sustainable primary care system and infrastructure. Building on Resolve's expertise in PHC and infection prevention and control, and Jacobs' construction engineering and design expertise in climate-resilient tertiary care, we've collaborated and we collected evidence-based recommendations and practical actions that will lay the foundation for climate epidemic-ready primary care system. With that said, and no further ado, I would like to introduce our two keynote speakers today. I would like to welcome first Dr. Tom Frieden from Resolve to Save Lives. Dr. Tom is President and CEO of Resolve to Save Lives, formerly served as Director of the CDC and Commissioner of Health of New York City. With over 25 years of leadership in public health, he has led transformative global and domestic initiatives, including ending the West African Ebola epidemic, launching large-scale heart disease prevention programs, and spearheading the world's largest effective tuberculosis control effort. He's a widely published expert on infectious diseases and health systems. Dr. Frieden, please.
Good morning, everybody, and thanks for being here. This is a new partnership for us and an exciting one. Primary care is at the core of what we've learned is needed in the world, what we've learned is needed for epidemics, for health promotion. And I want to have really a huge thanks to everyone who's worked on this project. It's been really intense. It's been very interesting for our staff. We have not had a partnership like this before with a private entity, and I think we've learned. I hope they've learned as well. So I really want to start with thanking everyone, including all the Resolve to Save Lives staff who've worked on this. When health systems falter, everyone suffers. The world unravels. And the message is really clear. Resilient primary health care is the first and best line of defense, not just against the visible epidemics and pandemics, whether COVID or Mpox or measles or yellow fever, but also the ones that are slow-moving and quiet and often invisible, like strokes and heart attacks from hypertension and unhealthy lipids. It's really an urgent moment because at this time, there are very few facilities around the world that are designed to withstand a surge in patients or a flood or a heat wave. It's been said that we shape our buildings and then they shape us. The built environment shapes our behavior. It reflects our values. It allows us to connect with communities. And smart but not expensive design is very important. It can be elegant but not elaborate, durable but not deluxe. Now, the only thing that is truly irreversible, and we're seeing a lot of damage being done around the world by various natural and human forces, but the only thing that's irreversible is death. And we can design systems that reduce the risk that people will die. Primary care is the foundation of that. It's where most people interact with the health system. It's where outbreaks can be spotted early. It's where patients can find a trusted environment to have the kind of care they need, to understand what's happening in their community, and to consider whether they want to accept the advice being given. Sometimes the barrier is the building itself. I've been in PHC facilities in more countries than I can count, and most of them are not terribly pleasant places. But it's not enough to have a really pleasant place. My very first job in public health was working for a beautiful community health center in the US that had no patients. So you really need to have that combination of good design and good community engagement. And what you'll hear with this Foundations for Sustainable Health is a blueprint for building a health infrastructure that's epidemic-ready, climate resilient, and sustainable, and designed with the active participation of the community. Because each community has strengths. And to address the health challenges or other challenges in that community, it's important to enlist those strengths. And of course, infrastructure isn't just about concrete or rebar or wood or bamboo or whatever you build with, it's also about people. It's about how we protect people with ventilation systems. It's about how patients move through a facility and whether that's efficient. It's about whether people feel respected, feel that they have dignity and care. Our most valuable health asset, of course, is the people inside. And in our work around the world, we've seen that all too often that fundamental truth is not recognized, is not respected, and is not reflected in how buildings are designed and operated. Now, we're thinking a lot about design these days, because good design results in a good product. There's an old saying, well begun is half done. Bad design can create essentially a manufacturing defect that is very difficult to fix. We are really calling on governments to embed resilience into their health and infrastructure planning, not as an afterthought, but as a foundation. We're asking donors and development partners to fund integrated, sustainable solutions, not silos. We're urging facility leaders and communities to be part of the design. Local knowledge is essential to building something that works and lasts. The blueprint offers a practical path forward, and I'm really looking forward to the panel that'll really infuse some reality into that vision. You'll hear from the people who wrote it, those who will implement it, and those who can help fund it. We can build primary health care systems that are prepared, equitable, and resilient. And I think the next step is to go from these really well thought out plans to seeing how well they interact with reality. There's an old saying attributed to President Eisenhower that plans are useless, but planning is essential. And I think what we know is that well, Mike Tyson may have said it best, everyone has a plan until you get hit in the mouth. Reality hits us in the mouth sometimes with the challenges of site selection and water and sanitation and approvals and how to get the work well done. So I think I'm really looking forward to learning more about this and then to exploring with all partners where we might be able to go to the first step really of the Resolve to Save Lives solutions pathway. We start with rapid prototyping, try out, see. It's okay to fail at that stage. See what works, see what doesn't, move quickly, and then when you have something you think is going to work, go to the proof of concept phase. See if it really is going to work, and if it does, figure out a way to scale it up and reach everyone who you want to reach, and then how to sustain it. Because ultimately, the bottom line is sustainable development. Thank you all very much.
It is my distinct pleasure to introduce Susanna Kerr from Jacobs. Ms. Susanna Kerr is an Executive Vice President and General Manager of Jacobs U.S. Federal and Environmental Business. With over 30 years of experience in operations and business development, she has led major transit, water, and infrastructure programs for governments and private clients. At Jacobs, she oversees more than 4,000 employees and up to $2 billion in revenue, contributing to consulting, design, and construction of complex environmental and infrastructure projects. She serves on Jacobs' Global Integrated Delivery Steering Committee and multiple joint venture boards. Susanna, please.
Great, thank you, Nino. First, I really want to say thank you to our partnership with Resolve to Save Lives and Jacobs. Having watched the creation of this blueprint over the past year, it's been a learning process for me, and it's been a true honor to kind of see this partnership and development and where we've ended up. So good morning to all of you. It truly is an honor to address all of you today. I know many of you as global leaders, you're gathering here today at the World Health Assembly to really discuss the future of our global health. As we've just heard from Tom, existing healthcare facilities are failing to adapt to stressors, leaving communities vulnerable and in a constant state of mitigation. We must transform the primary healthcare system, and this begins with infrastructure. As an architect and city planner, I've been drawn to designing sustainable and resilient spaces that not only serve the immediate mission and purpose, but also adapt to evolving global changes, from accessibility and efficiency to emergency preparedness and lines of attack. Like Tom said, it's not just about the tangible elements. It's about creating environments that foster health, safety, security, and well-being for staff, patients, and community members that it all serves. Resilient infrastructure ensures that facilities remain operational during extreme weather events, epidemics, and other emergencies by providing uninterrupted access to essential services. It also contributes directly to epidemic or emergency readiness by ensuring that healthcare facilities can quickly adapt to surges in patient numbers and evolving health needs. So some examples. Modular designs allow for rapid expansion or reconfiguration of spaces to accommodate isolation wards, vaccination centers, patient flows, or things as simple as windows that offer natural ventilation but with adjustable openings and protected with insect screens to prevent vector-borne disease transmission. These examples of flexibility, and we'll hear some more in our discussions today, are crucial in managing outbreaks and ensuring efficient and sustainable delivery of care. When it comes to climate, there are two interconnected concepts that must be addressed: the impacts climate-driven events have on the facilities and the impact the facilities have in contributing to greenhouse gas emissions and overall climate change. The solutions we implement must make the infrastructure more resilient to the damaging effects of cyclones, heat waves, floods, water surges, while others supporting sustainability by integrating low-carbon materials, renewable energy sources, and passive cooling systems. Again, infrastructure is really here to support the enhancement of the medical profession and the services that are offered and the solutions we provide, not to deter from that. These design elements not only protect the environment and significantly reduce the carbon footprint of health facilities, they also enhance their operational stability to ensure they remain functional during adverse conditions when traditional systems are failing. This particular blueprint is an important step towards unifying approaches to epidemic readiness, climate resilience, and sustainability. However, I want to emphasize the importance of building infrastructure with a community. This is not for a community. By taking a user-centered approach to design and aligning clinical best practices and infrastructure standards, we can ensure that primary healthcare facilities are equipped to withstand a wide range of threats from maintaining essential services. The future of healthcare calls on us to all do better, and I truly look forward to the insightful discussion that we will have as part of our blueprint. With that, thank you.
And now to the panel. I'll be calling out the panel members and giving you a little bit of the background, and while I call out your names, please take a seat. I would like to start with Dr. Landry Duomo-Tsagi, from Africa CDC. Dr. Landry is the inaugural director of the Africa CDC's Center of Primary Health Care. He leads a continent strategy to strengthen the public health care systems as a foundation for universal health coverage and health security. With over 2 decades in global health and public health system strengthening, he has held leadership roles at UNICEF, Columbia University, and Cameroon's Ministry of Health. He has co-founded the Pan-African Medical Journal and has advised on major initiatives, including the Pandemic Fund. Thank you for being here. Dr. Mesai Hailu from Ethiopia Public Health Institute. Dr. Mesai is the Director General of the Ethiopian Public Health Institute. He's a seasoned leader and public health expert with over 2 decades of experience across academia, health administration, and policy. Prior to joining EPHI, he served as Vice President of Hawassa University and held various academic roles, including Associate Professor of Public Health and Epidemiology. Dr. Mesai has led health programs at both regional and national levels. Thank you for being here. And Amanda McClelland from Resolve to Save Lives. Amanda is the Senior Vice President at Resolve, where she leads teams working to make the world safer from epidemics. She has published a landmark study with the World Bank on the cost of healthcare worker infections during the COVID-19 pandemic and received the Florence Nightingale Medal for exceptional courage in her role in coordinating the frontline response during the 2014 Ebola epidemic. Thank you, Amanda. And last but not least, Mr. Matthew Holmes from Jacobs. Matthew Holmes is the Global Director of Health Infrastructure at Jacobs, leading Jacobs' health planning and design teams worldwide. He brings extensive international experience in healthcare design with deep expertise in clinical operations and designing for safe, efficient patient care. A frequent presenter and published expert in healthcare design trends, he focuses on health demand analysis and how built environment can support the pandemic preparedness. Thank you, Matthew. With that said, I will transition as a moderator. Please use the mics. With no further ado, I will start with Dr. Landry. Dr. Landry, would you mind giving us a quick overview on Africa and the state of primary care infrastructure when it comes to being epidemic ready and climate resilient?
Thank you so much. Good morning.
Good morning.
It's a bit rainy and cloudy this morning. I hope that you are all warm, right? I think the topic today will keep us really warm because it's at the center of the theme of this World Health Assembly. Health for all. Health for all cannot be achieved unless we build the foundations. And I was so happy when I saw the title of the blueprint. It's really about the foundation. It's the foundation that is needed for sustainable health. So I think this blueprint is at the heart of what we all need to commit to achieve if universal health coverage, as defined in our SDG target 3.8, should become a reality. I think the continent of Africa is at the heart of why we need to achieve universal health coverage and why epidemic-ready and climate resilient primary health care infrastructure is at the heart, or is the backbone of that ambition. I bring the greetings from Africa CDC, and we are very privileged and honored to be part of this panel today. Africa CDC is the continental public health institution established by the African leaders in 2016. And I want to insist on that because we are privileged to have Tom in this room. The Ebola epidemic in West Africa and what the continent suffered, community went through difficult time. And the system at the bottom line for the detection and the response to the Ebola outbreak is the system we're talking about today. We clearly understood at that time that Africa was not ready. And the decision was made to ensure that it never happens again. So Africa CDC was established with that mandate to safeguard the health of the continent. We went through COVID-19, and Africa CDC took a central role. In that response to the COVID-19, it became more and more evident that the new public health order, which is our mantra with the 5 pillars, one of them being the strengthening of public health institutions and systems. The second one being strengthening the workforce, because we will not achieve universal health coverage if the workforce is not central to our system. Africa CDC, after the COVID-19 response, took bold decisions with the support of our member states. One of them being to advance the local manufacturing. Local manufacturing, obviously why? Because during the COVID-19 response, Africa was left behind. Yes, we know it. We voiced it. Our leaders voiced it. And today, the conversation around primary health care, we have to also link to the one around the commodity security of the continent. So local manufacturing is an important agenda, even more important today with what is going on around the global financing for health. So why am I going through this background? I really want to start there because primary healthcare infrastructure on the continent today is reflected by the current estimate of the coverage of universal health coverage on the continent. The last report from WHO estimates that the continent has achieved about 42 out of 100. This is an index. But the higher the index, the better your UHC. We have to achieve at least 80 over 100. And across the 55 member states on the continent today, none has crossed that or reached that target of 80 over 100. None. So it means that we are still far from where we should be, despite the progress that we are making. Some countries in the northern part of the continent have reached 70, 60, but not yet 100. But the majority are below 50. And those below 50 includes those affected by security crisis, climate events. The southern, the eastern part of the continent with frequent cyclones, yes. What type of health system do you need there? May not be the same in other parts of the continent. So let me stop there for now. I'll come back with more details about how, as Africa CDC, we are responding to this reality. Thank you.
Thank you, Dr. Landry. That's very sobering numbers that you brought in there, that none of the countries has crossed the 80, the mark, the index. So maybe I'll go to Dr. Mesai next. Maybe Dr. Mesai, would you mind giving us a little bit more country perspective? You represent Ethiopia particularly, so maybe build on Dr. Landry's reflections and tell us what are the challenges in primary care system in Ethiopia, and are there any major initiatives addressing those challenges?
Thank you very much. I would like to, first of all, I would like to thank the Resolve Save Lives for innovative approaches as well as interventions that we have been collaborating with them. They introduced the Epidemic-Ready Primary Health Care Initiative, which has been very effective in pilot and implementing areas. That there is a collaborative surveillance, as well as the 717 initiative, which we have been adopting to our the system and found it very effective. I would like to really appreciate and thank for this wonderful, innovative, and tailored interventions, which can easily be fit to purpose in our setting. To reflect on the primary health care in Ethiopian context, as everyone knows, primary health care is the backbone for every health system in Ethiopia. Huge investment have been made in advancing and improving, as well as substantial expansion of primary health care, and which is effective, cost-effective, as well as affordable, accessible, and impactful for the community, particularly in developing countries like Ethiopia, where stretched health systems with many man-made and natural disaster or health threats are prevalent. So in our context, the substantial expansion of primary health care, particularly in rural areas and underprivileged areas across the country, have been effective, as well as one of the exemplary programs in the country in addressing major public health problems. They also shoulder most of the package shoulders most of the essential public health functions. All package of essential public health functions are addressed and provided to the community as primary health care level. So primary health care system and program is the backbone for Ethiopian healthcare delivery system. Almost more than 80% of services are provided through this platform and this system. The major challenges in primary health care delivery in Ethiopian context is particularly in border areas, in underprivileged areas, the poor infrastructure, the poor facilities, for example, particularly the water, hygiene and sanitation facilities, and substandard infrastructures are the major challenges, particularly in case of public health emergencies attributable to man-made and natural disasters. But the country has invested a lot in addressing those problems, and tailored and innovative interventions have been introduced and in place. But the challenges are not limited to this wash facility, for wash facilities. Even it's beyond that. Then in accessibility challenges, particularly in geographically hard to reach areas, are the major problems. The health workforce, limited number of health workforce, qualified health workforce, particularly in rural settings, are also the major problems. And resource constraints are also sustainability of the sustainability of services largely affected by this limited resource allocation, particularly in lower administrative settings, and the limited infrastructure, the substandard infrastructures, particularly in hard to reach areas, as I mentioned, are the problems. Poor equipment, supplies, and similar challenges have been the major problems and challenges in effectively providing primary healthcare services in such settings. And the initiatives to address those problems that the country has introduced are just the reform, and primary healthcare is one of the major achievements. The Minister of Health made a significant reform in improving primary health care delivery system in the country. For example, in the ministry, there is a lead executive office for community engagement and primary health care, which well aligned with the epidemic-ready primary health care system, which is in which is one of the innovative initiatives introduced by Results to Save Lives in collaboration with Ethiopian Public Health Institute and Public Health Emergency Management. We have well aligned that with the ministry's programs section, that is the community engagement and primary health care. There is also another institute in the ministry, the International Institute for Primary Health Care. That is actually both of the directors are here. So that is a major reform and action to improve primary health care challenges in the country. The other is resource allocation, community participation engagement, and improving the governance of primary health care system, particularly at subnational level and in the regions, as well as districts and in the districts. The challenge is, in Kabale, or the lowest administrative level, particularly where the community gets service from health posts, which are the primary provider of primary health care services. All the packages, health extension program packages are there. They are well aligned with really these essential public health functions, but the fragmentation of services and systems across all levels, from national to the district level, and it's further alignment, improvement, as well as just division or devising of innovative approaches for that. And the other initiatives the government has been doing is the capacity building of the health workforce in pre-service as well as in service trainings. And these are the major activities to tackle all the challenges that we have identified in primary health care. Thank you.
Thank you, Dr. Masai. And I appreciate the deep dive into challenges and some initiatives from Ethiopia. Amanda, I want to come next to you. You, Resolve to Save Lives, have been mentioned multiple times, that worked heavily on the African continent, and particularly in Ethiopia and other places, other countries, to improve the epidemic readiness and pandemic preparedness. And you and your team have worked in this space extensively for a long time. So what happened last year when you and I talked? You were excited to hear about the infrastructure component that we Jacobs were bringing to the table. And what did you see as a limitation in your work in pandemic preparedness that led you to explore the health infrastructure as a part of your work? And how does this blueprint that we worked together addresses those gaps and challenges?
Thanks so much. I think the big innovation for me last year was that infrastructure always felt like an unsolvable problem, right? It was something that we just had to work around. I'm a nurse by training and started in primary healthcare 20 years ago now in Australia in a remote area 12 hours away from the nearest hospital, and we got hit by a cyclone, a small indigenous community, and the primary healthcare facility was the shelter for the community. It was the only source of power for several days. It was the only source of clean water for more than a week. And the primary healthcare centre was built in the centre of that community, not just to provide care, but for safety. And from there, I started a career with the Red Cross and went from that facility in a very remote location to running immunisation clinics under a tree. And you can do it. I ran malnutrition clinics out of Manyatas in Uganda. You can provide healthcare without the infrastructure. But several times it wasn't safe for me or for my patients. And I'm so glad that our Sierra Leone colleagues are here, because in 2012 I went to Sierra Leone as part of the Red Cross for a cholera outbreak. And one of the first things I needed to do was buy an angle grinder to cut our way through the fence and through the railings to create a flow for patients in the cholera treatment centre. When I arrived, the nurses had done the best they could, but they were taking cholera patients through the surgical unit, through the maternity unit, to the cholera treatment centre at the back of the hospital. And one of the first things we did was cut a hole in the fence so that patients could come in the back way. A few years later, I went back to Sierra Leone for the Ebola outbreak, and again, the infrastructure was a major limitation. And when I worked in Kenema Hospital, the nurses were managing and doffing and undoffing in the dark. And one of the first things we saw was a nurse come out of the makeshift Ebola treatment center, and a nail had ripped her PPE open and cut the skin. And we were so frightened at the time that just a simple infrastructure challenge of working in the dark with nails coming out was going to cause Ebola transmission. So infrastructure has been a key barrier in my nursing career and in my humanitarian career. And I think something that we just thought we had to work around. And I think Jacob's presentation and focus on infrastructure last year, and I think a new momentum that we can do better and should do better, really ignited this work. And as part of the initial scoping of this, there's nothing new in this document. We found more than 24 guidance documents from organizations around the world that addressed individual pieces of this. There was a good WASH document. How do we do sanitation here? How do we do waste management there? Too often I was speaking to partners who were telling me that they were going to do WASH in 100 health facilities, and then another partner was going to do digital infrastructure in 1,000 facilities, but they weren't the same facilities. And so we have this patchwork of infrastructure, some water here, some digital infrastructure there, autoclave over there, but very few of the clinics we're working in have the whole package. And I think we can do better. And I was inspired by Dr. Landry and the Africa CDC talking about a transformation of primary healthcare, and we think that that needs to start with the building. We can't provide good quality care. Nurses shouldn't be working in the dark. We shouldn't be asking healthcare workers to protect themselves from infectious disease without water. We can't be asking for more surveillance data if they don't have the digital infrastructure. And we can do better. All of the innovations are there. We've just been implementing them in a silo. So we're super, I've had such a fantastic time working on this project with the innovation and design thinking and the architectural solutions to some of those problems that I thought I just had to put up with. And so this is really the call to action, that we can and should do better. The solutions are there. Countries have been innovating in this space, but we haven't been able to work with them to pull it together. And I think that's the innovation here. How do we transform the pieces of the puzzle to make sure that healthcare is safe and effective, both for the staff that work in it and the communities they serve?
Thank you, Amanda. Thank you for sharing the personal examples. And to be honest, from our work in Jacobs, we know that you don't have to put up with some of the challenges that you were listing here, that nobody should be experiencing what you have experienced. And I want to call on my colleague Matthew, that we've designed and built those facilities around the world. And you bring, Matthew, a deep expertise in designing resilient, sustainable infrastructure, both primary, tertiary, and many different in between. And I want to maybe ask you, how do you see this challenge, and how is your expertise informing the recommendations that we put in the blueprint, and how do we solve integration and standardization of infrastructure to incorporate the climate resilient practices to make them epidemic ready, safe, and reliable for healthcare workers as well as the patients that go there?
Thank you, Nino. To some degree, I think I've got the easier part of the answer here, because many of the people earlier have already responded to some of these elements, and I'll pick on some of the things that Amanda's also picked up on. It is about bringing these things together at a holistic view, and I think that point you just made then around this sort of discombobulation of different things. How do we start to bring it together to be one approach? I suppose one of the things very proud of in this work we've undertaken here is to look at those systematically, those components, and start to frame those out as a guideline or a methodology to think and reflect on. So when I started that, certainly the challenge we were looking at hand is sort of location. Primary health care is the foundation of the health system. How do we provide a network which is accessible to a population? How do you provide that in a location? And then start looking at some of those site-specific elements. We talk a lot about, over the last few days, some of the challenges of the environment, of access to water, heaters, overbearing heat and the likes. So how do you look at those site elements and try and maximize the response to those items? When I then look at some of the buildability challenges, one of the things we really do look at, and I have to say this is across all types of projects, is I say buildability. What are the materials? What are the access to materials? How do we construct or deliver buildings which are actually buildable and maintainable in their context? Because there's no point me arriving with some solution that works in some location, is not deliverable there, and not maintainable, because I think that's the other one that we see a lot of. If we can provide some solution, but actually is it able to be operated and maintained over the longer term? Some of the responses within the building typology, things like the natural ventilation for heat. How do we have a solution which is energy efficient, water effective, responds to things like infection prevention control, is utilizable by staff and workforce? And I really want to emphasize the workforce. I think to some degree we see this globally. The people delivering the services in these locations, how do we really support them to the maximum possibility? They probably have been under considered in some regards, and I would put a large focus on that. So some of the other things we talked about, I think at the operations level, things like the waste management, I see facilities where there's a real challenge, and you talk about the autoclaves not functioning and the likes. How do we have systems that are resilient over the longer term, that are operationable? Safety and security, again, is another one. And I talked about waste. So there's some of the areas I would touch on. What I would say, though, Nino, is you talked a little bit about standardization. How do we start to bring these learnings and improve on them, and not start reinventing different components all the time? We sometimes talk about some of the kit parts or the components, certainly at training level. How can we help the workforce So when they're working in different locations, not it's different every time. So that would be some of the efforts we are making significantly across all spheres of the health infrastructure domain.
Yeah, you clearly want to reflect, Dr. Landry. Go ahead, please.
I was just nodding as you were speaking, because I think you are hitting the nail on the head. The continent of Africa will leapfrog. UHC targets at the moment is not reached by any of the 55 member states. But the question is about how do we leapfrog? We won't try to reinvent the wheel, but I think the work that is presented today by RTSL and Jacob is one of the pieces of the puzzle that we need to put together. You mentioned that. At the Africa CDC, the narrative has to be different. That's what we said. And I was also telling Amanda that at Africa CDC, at the Center for Primary Health Care, which was established only 6 months ago, yes, because we had to make a bold decision to step up our strategic agenda and to invest in establishing one of the 5 centers, being the Center for Primary Health Care, that I have the humble privilege to lead today. And from the day I was appointed, the biggest challenge that was already on my table was, what's Africa CDC going to do on primary health care? And I'm sure Tom, who was leading CDC in Atlanta, the question is CDC on primary health care? But that's not where we expect you. You should be doing epidemic response and preparedness. But the question then is, how do you do preparedness? How do you prepare the system to cope with the threat? How do you ensure that it's resilient to climate stress? And how do you make it ready to be activated regardless of the level of the threat? So those critical questions are somehow part of what engineers would call the user specification for a design process to be informed by the needs. So today we are clear about the need for primary healthcare transformation. And that transformation should even start by the name. Why did we call it primary healthcare? Why is it so focused on care by definition? It should be about system for health. It should be about prevention more than care. Yes, that's what the continent now is looking at. So from PHC to PHS, primary health system. And some of our colleagues who are economists are even challenging the term primary. They are telling us that it's making it difficult for them to understand where are our priorities. Because the economists look at the priority where we want to put most of your investment. But we are telling them, yes, we can reach 60% of our population with a basic package of services by using that system. But then they say, but why are we calling it primary? It's a priority system for your return on investment. So I'm just bringing that to you to understand, to make you understand that this is a strategic agenda for the continent, and the transformation is going to be very, very deep. The second pillar, narrative is not a pillar, sorry. Narrative is, at the end of the day, we decide whether we keep PHC or whether we change it in Africa. Because it has to bring in the political buy-in. PHC doesn't mean much for a politician, right? For an economist. What is the hook that we need to bring as we redefine this agenda on the continent? Second, now we are now working to finalize the narrative around the 6 pillars of the PHC transformation. Let me start with the one that is close to what we're talking about today, the pillar on digital and infrastructure transformation. But we are saying that designing climate resilient and digitally enabled primary healthcare facilities, with reliable solar power, clean water and sanitation for infectious control, and telemedicine and data system to extend services reach and real-time oversight. That's the vision. And we know it's possible because it's already happening in some places on the continent and outside the continent. The second pillar is the workforce transformation. I think you mentioned workforce, right? And what we want to focus on is not to do more of the same, but is to challenge the conventional thinking that is not yet recognizing community health workers as part of the critical workforce in Africa today if we want to reach the threshold of 80, right? That we need to fix it. So we want to institutionalize community health workers as the front line of care, prevention, and support, in line with the AU commitment to reach 2 million community health workers by 2030. 2 days ago, we published a study that estimated that today on the continent we have reached 1 million training and deployment of CHW, but we need to reach 2 million if we want to cross the threshold 80 over 100. The third pillar is the community security transformation. I mentioned that earlier. Today, the ODA reduction from 81 billion to 25 billion translates into exposing our public health systems to frequent stockout. Or somehow, we may have to buy commodity at a higher cost if we don't have a system that pulls our needs and negotiate a lower cost. So that transformation brings in local manufacturing as a priority for Africa CDC on the continent, and pool procurement that Africa CDC now has established through the African Pool Procurement Mechanism. So commodity security transformation to bring a comprehensive package of services at the lower level of our system and ensure that there is no stockout. The fourth pillar of transformation is the financial access transformation. Yes, we need to reduce the shocks that is linked to access to services. And I want to share with you, I'm sure you saw this publication already, I'm sure Tom have seen it many times. This is what our head of state requested Africa CDC to work on, is to redefine, rethinking Africa health financing in this new era. There's no way we can talk about primary health care and UHC if we don't answer the question of who is going to fund it, how we're going to fund it, and how we're going to sustain the investment. Because primary health care is primarily the responsibility of the government, of the state. Partners definitely are needed. Catalytic investment is needed. Private sector is going to be critical. But at the end of the day, Africa will have to finance its primary health care systems. The last one is quality of care and data transformation. Not the last one, the fifth one. And the last one is governance and accountability transformation. I'm sure you heard about the Lusaka agenda, which really calls for rethinking the way we organize ourselves to prioritize primary health care investment if you want to achieve and fast-track universal health coverage. So let me stop here and let me commend again RTSL and Jacobs. We look forward to host you in Addis Ababa pretty soon for a continental consultation to translate this blueprint into something meaningful for our member state of our continent. Thank you.
Thank you, Dr. Landry. Thank you, Dr. Landry. I'm actually very pleased that you are taking on the concept of how do we standardize the approaches to healthcare infrastructure and then everything that comes out of it. I actually will ask Amanda and Matthew to comment on standardization and the scaled deployment, but before I go there, Dr. Messiah, would you want to add something from country-specific perspective and talk about maybe how blueprint or standardization to infrastructure could help the Ethiopian primary care system to transform into the better system?
Thank you very much. I think I have seen it adaptable and it can be tailored to the existing system instead of just devising a novel or new kind of system, because every country has its own context and challenges. The blueprint is very adaptable based on the assessment and the gaps identified, and most of the issues raised in the document are very well aligned with the system, the challenges we have been facing day to day, and this can be adaptable, and we can also align it with the governance system, the structures, from national to sub-national level, and it is very helpful. But I like the statement, the standardization. Most of the primary health care facilities, even not only the structure, but even the infrastructure is not well standardized to the purpose. We packed the primary health care system with a number of packages and interventions, but it needs really, it should be aligned, well aligned with the physical structures of the facilities that, for example, for infection prevention and many other packages that have been mentioned here, and we are very much happy, and we can also adapt this to our local context. Thank you.
Thank you, Dr. Mesai. Matthew, I want to come to you next because you and I had a lot of conversations about how do we help the countries to standardize their approaches to healthcare infrastructure, because there shouldn't be such a huge impediment to providing services in healthcare services, basic or more advanced. And I would like to hear your reflections on the context of the cultural implications, because one is to standardize the approaches, but we also need to be sensitive to the cultural particularities in the country, if you don't mind, to maybe reflecting.
I mean, I suppose that's the same with delivery of any infrastructure solution. It's local context. There are different ways of doing things. There are different cultural expectations and norms. So when you take an approach of standardization, I don't think it means you're going to do everything around the whole globe the same way. So first of all, everyone accepts, sorry, yeah, I remember you said you have to...
Thank you, no problem.
Thank you. So first of all, we still need to build in locality, almost locality specific, and that can be cultural, operational, and the like. So accepting, whilst an approach to standardization doesn't necessarily mean it is literally the same everywhere. However, what we can do is still look at repeatability and scalability in a context. So if we were going to take a geography or a location, what are the learnings that we can do to repeat and deliver the benefit? We know things like standardization, why people are interested in it, for a myriad of reasons, things like safety. If we have a sort of a standard model or template that workforce are familiar with, it improves operational safety and the outcomes. It also improves deliverability, speed to construct, speed to deliver, and there's also cost effectiveness or cost efficiencies when we start doing that. So there's a range of benefits, but I do accept, Nina, your point around we do need to be contextual to the locality. The other one I think is really important is also the feedback loop. How it's not a one-off and that is it forever. It's a continuous improvement process. So what are we learning from the delivery of infrastructure in its context, and how do we continuously improve those outcomes? So there needs to be a methodology of improvement and fair to say, augmentation of what is being undertaken. I don't know, Amanda, if you want to add to that at all.
Yeah, I know we're almost out of time, but I think what I'd like to kind of leave here with is, from Resolve's perspective, this is the start of a conversation, and I think an acknowledgement that we don't have to put up with bad infrastructure, that bad infrastructure is a solvable problem, that those innovations are out there, and it's about how we bring them together in a more coordinated way, in a package way, that we think about a minimum standard that healthcare workers have the infrastructure that they need to do their job properly, and that communities have a location that provides service in a way that is responsive to their needs. And we haven't touched on it as much, but I think the role in decarbonisation, and that was one of the very initial conversations we had, is how do we bring these three pieces together in an integrated way to solve challenges. And I think I leave here knowing that we can solve that challenge, that we don't have to put up with bad infrastructure, that we can do better, and it really will lay the foundation for transformation of primary healthcare, not just in Africa, but in several regions around the world that are struggling with these same issues.
Thank you. Well, I will close pretty soon, but if any questions from the audience, please go ahead. Oh, there's one mic over there.
Thanks. And I'm just going to ask Sierra Leone, given I've talked about them so much, and I think they've been leading in this way, to perhaps make a comment as well.
Oh, there's also the question over there. Please go ahead. Yes.
Thank you very much for pulling this together. Thank you, Dr. Frieden, colleagues. For us in Sierra Leone, as Amanda have been talking, we've seen primary health care as the backbone and the only way to actually go through UHC and specifically for health security. Because we are looking at saying you need the primary system, the secondary, the health security, and then the networks. But you can link the primary to this health security very well. And of course, when you take the primary health care from our side, you have 4 things that you really have to look at very well. The infrastructure, as we are talking about, is key. We need to look at the supply chain, the equipment that are there, but then above all, the human resource that is there, and then of course the digital. So for us, our primary health care system is also a tier, these facilities, but as he said, in Africa, most of the other places, 60% of the population can harness those places. For us, it's more than that. Up to 80% of our population are served by this primary health care. So using that to really do some of these things will be the right way to go. What have we done in preparedness? We always talk about preparedness and response. Infrastructure for epidemics could be a preparedness way, a way to prepare. The human resource that you get. So what do? We have the staff that are here at the primary healthcare level, the facilities that are different levels. We also have it in the community. So in preparing for these things, we have what we call the FETP, I know, Tom, the field epidemiology training, which almost all these facility staff are subjected to. And then we have, that's the intermediate, we have the front lines, and we even have the community one. We call it light, yeah? So at least give them the structures, what to do. So with this, we can actually detect as early as possible. But then in the time when there is no pandemic or epidemic, these people are still in these facilities doing their normal nutrition surveillance, maternal mortality, these things. But at the same time, as they focus on it, they can pick something. And then, of course, we have a digital system, the IDSR, so we get the information quick. So we really detect a bit early. But then, because we've not completed in the preparedness, and then the response is at times challenging. We start the response, but the preparedness keeps you there. Why am I linking it to this now? She told you. We have this team, they know what to do, but their instructions, the way they are built, you can't use it most times when really you find an epidemic running. So if you notice, she was there during Ebola. Almost all the health facilities were deserted. I could remember when I was in Bo, the first Ebola case that came to the hospital, because they entered through the same gate with any other person, all the patients, apart from the comatose patient in that big hospital, all discharged themselves. You see that because if you don't plan it well, if you don't build it well to ensure that the patient flow encourages something good. Because in our system, we have been living with, there are times we have 6, 7, 8 epidemics going at the same time. She can bear me witness. So we have the shock. The human resource is strong to resist those shocks, but the enabling environment is the challenging thing. Because we don't know how to construct. Our engineers may not be strong at that, so we use what is available. So trying to make that brings all these problems and challenges, even getting the health workers getting infected because you have to manage, the things are not there. Yeah. Some of the buildings we use, Tom has not been there, you know, even the ventilation, the lighting system. So bringing things like this as a very good way of a preparedness plan, so that at least you make sure that even in the midst of pandemics or epidemics, you can still use the same facility to handle it. It's okay. So most times what happens, why this is important, if we now eventually turn these institutions we have into holding or treatment centers, we are going to lose so many people, not because of the epidemics, but the pregnant women are no longer coming. The other cases are no longer coming. We don't know where they are. The community, they even are most times afraid of health workers because they think if there is a pandemic or epidemic, the health worker is always fighting it. So the more you move away from the health worker, the better. So you may have a lot of mortalities due to other areas than even the epidemics that we are fighting. So having the structure that can really be a cushion to, at the same time, do your response to your epidemics and at the same time handling your normal things is something that will be very vital to have. Thank you.
Thank you so much. And I can, on behalf of Resolve and Jacobs, I wanted to say that we have collected our best practices, engineers and architects, to design that blueprint that actually expands and adapts to many different scenarios, because that what if you have this type of shock or then another type of shocks? How do you keep providing the services is really important. So we are very happy to share our work with you. Go ahead.
Thank you very much. Thank you very much for this presentation. My name is Patrick. I work with AFINET, African Food Epidemiology Network, and we are very happy with the work that we've done with Resolve on the Epidemic-Ready PHC, particularly the infrastructural development and wastewater management, WASH, that have really, really been helpful. So I have two questions, one political, one renewable energy. Maybe I start with the renewable energy. Harvesting solar energy in an African context is easy. The biggest cost is the storage. A basic lithium battery is $1,000 US. And as Amanda said, energy for lighting and for basic, newborn unit and all these things is so critical. Are there cheaper options for that? So that's one question. The other question is the political one. PHC revitalization is becoming a political agenda in many of the African countries. Launching a PHC is of political importance. It gives you political capital for the politicians and aspiring politicians like me. So the politician is not very interested in coverage, safety, and the other nice indicators. He's interested in, I have launched a PHC. So in our experiences on technical, operational, political influence, I wonder whether we can tie it with the political, financial sectors to see if a politician can say, I have launched a epidemic-ready, cardiovascular-ready, climate-resilient PHC, or I have refurbished. Because that's also another nice indicator. And my brother in Ethiopia, I'm sure you'll agree with me. So is there a way of packaging around that to buy that political sort of will? Thank you.
Yeah, maybe I can, I'll answer the political question. I do think setting standards and certifying PHCs is a way forward, right? That you shouldn't be able to build a PHC without the minimum standards of infrastructure. And as we go forward, making them future ready. And that includes then the digital infrastructure that we need to make sure that our healthcare facilities can go forward. And so I think that's a conversation that we'd like to start and to see how we move that piece forward. I don't know the answer to the battery cost question, but we'll get back to you.
I mean, I might just add that I suppose there's two parts to that. One is the capital cost, and the other one is the operational cost. And traditionally, we may have had generators or the lights in locations or something, but the operational cost of those is not inconsiderable as well. At the moment, yeah, batteries probably are expensive, but there is a trend of these things getting probably more cost-effective. But then the other one is, are there other alternative solutions to, in some locations for some of our clients or people we work with, there may be things like wind or something, but that depends on the location. So I suppose an assessment of what's appropriate to the context is my advice. Sorry, I can't give you it cheaper there, instantaneously.
Thanks. My name's Louise. I'm the head of the liaison office here in Geneva for UNOPS. And I'm just saying I'm super excited to see this project up and running now. As the UN agency that deals with infrastructure and procurement, obviously we've been constructing health infrastructure and procuring supplies for the infrastructure for 30 years now. We have a great rural electrification project in Sierra Leone, and I'm really delighted to see this coming together because I truly believe that we need a bridge between some of the public initiatives that are going on through the UN agencies and the likes of what you're doing now, which is phenomenal. And Amanda and I spoke at the end of last year about the whole concept of blueprints, and our team in Copenhagen is now actually trying to push forward with the blueprints that we've been working on, from small PHCs to large oncology centers and specialized treatment facilities. So we are a self-financing organization, unfortunately, so we aren't able to proactively go out and do the things that you've done now, which is amazing. But we also have a lot of material, we have a lot of standards, we have a lot of model designs, we have a lot of modular designs that we would love to add to this conversation, and working with Africa CDC and other partners on the continent to really push forward and share all this information and expertise, and then create these PPPs that can really scale up initiatives like this, which are, of course, so important. Thanks.
Thank you.
Hi, Ludis Rantoro, so I'm the head of unit for multi-sectoral engagement for health security preparedness. So I just would like to congratulate this site event is really timely. But I would like, I don't think I have the question, but maybe just to complement. So since 2020, we do have the resolution on urban preparedness. And we are looking at infrastructure as one part of it. But it's the whole ecosystem. So it's not only just health services, but it's also transportations, the challenging community, housing, and so on and so forth. So I would like to propose to maybe we can collaborate, because we are finalizing mapping, infrastructure and capacities. Looking at how many diagnostic centers, how many clinics there is currently public or private, and then looking at also other sectors, facilities such as military services, medical services, that is, and police, trauma, hospitals, and so on and so forth. So we are mapping the whole system, ecosystem is coming in, and what is the primary healthcare. In terms of primary healthcare, UHC, and health security, we are been discussing about integrating some policy of health security preparedness risk assessment into the primary healthcare as well, because detection is often detected at the primary healthcare. Everybody goes there. And then extended in terms of surveillance, but it's also facilities like PPE and also training the workforce for a better detection in the future. So we are about to establish this technical working group to finalize this tool, and then we are also discussing with a early discussion with the OPEC fund in terms of resilience and rebuilding Syria. So one of the key aspects is the destroyed of primary healthcare around. I think just last point, the perception of risks and challenges is different from, I'm looking at global. In Latin America, we are talking about safe hospital, and we already established safe hospital index. And their risk is more about security risk, because primary healthcare is sometimes the hostages by the criminal group. And then, in the other, length, it's about, earthquake, as in Asia and others, natural resource and natural disasters. But last but not least, whatever we need to create the foundation, I would like to go back to the foundations of the IHR. Epidemic can, pandemic can happen, naturally occur, accidental, and also deliberate. So that deliberate is also one of the key aspects because it's the primary attack in terms of targets. So we need to think about how this is going to be compliant in the future.
Thank you. And there's one more question.
Thank you very much. I'm Dr. Gerard Mutunji from Uganda, Ministry of Health. Yes, and thank you for working in the Manyata. I liked your insistence of saying we can do better. It's possible. But I was waiting to see whether you have estimated the cost and where is the money coming from. Of course, I know the cost will be different in different circumstances. But there is issue of financing this very beautiful idea. So I wanted to hear about the cost and how are we going to finance it. And when you come back to Uganda, the situation is much better now. Thank you.
Thank you so much. Look, financing, we had hoped the banks were here, and we have spoken to Asia Development Bank and World Bank. Unfortunately, our colleagues from the bank couldn't join at the last minute. But I do think financing has been the biggest barrier, but also the biggest excuse. And I think one of the challenges I would put back to the governments is there are these initiatives about water here and digital there. It's how do we bring them together? There are new PHCs being built, but are they being built to standard? To Patrick's point, you know, they're built for political launches without the right infrastructure. So I think we can do more with what we have. Better planning, better implementation. Obviously, if we're going to scale to the level that Africa CDC was talking about to reach 80%, there needs to be a lot more primary healthcare, and so how do we finance that? So I think the conversations are with the bank. These are big infrastructure costs, but for too long we've let the money be the excuse for not keeping our health workforce safe and for not providing the right environment to provide care. And so I don't have the checkbook with me, but I'd love to continue the conversation. And I think continuing to work with the banks and demand a minimum standard in what we're already building is a big, or refurbishing is a big first step.
Amanda, I want to actually add on a cost factor, and I want you all to consider something. We are talking about the access to care, not only in the low-resource countries, but also everywhere. In Australia, we've seen struggles to access to healthcare. In the United States, we have access to healthcare issues. But what we are providing here is actually bringing multiple different solutions in one approach. And instead of, let's say, implementing the climate resilience program separately, implementing the pandemic preparedness separately, implementing WASH initiatives separately, we are saying, why don't we bring all of these initiatives in a single design blueprint? Think about the savings from overlapping these programs instead of doing it in a silos. It's not that we are like creating something that has never existed before. What we are suggesting is why don't we integrate all of these solutions so we are solving it once and not multiple times over and over, which actually, in my opinion, leads to the waste of resources. It can be the financial or any other resources we are talking about. So I think we need to urge the financiers, policy makers, and decision makers to think about the cost savings that happens from synergizing multiple programs, not only in Africa, in Southeast Asia, and in developed countries, because nobody has the endless resources. I come from the United States. We struggle with the same issues in some parts of the country. Amanda, Australia, struggles the same so it's not the unique challenge about the finances and the low resources. Please, Lois, go ahead. And then the lady in the back also wants to comment.
Yeah, just to complement that, I mean, I think, again, there are many initiatives that can be joined together because clearly there is duplication and overlap. And to your point, there are 5 MDBs that went out 18 months ago with WHO and said, let's do the Health Investment Impact Platform. It's out there. Those 5 banks are signed up. There's a list of 13 countries. Ethiopia is one of them. Where there are assessments going on to look at the prioritization of the health investments, of which, of course, infrastructure is one. So again, I don't know whether you're familiar with that initiative, but again, I think we need to move ahead with this, but we need to kind of join these platforms and initiatives together somehow.
Thank
Thanks.
you, Liz.
Hi, my name's Mariam from Empirical Health. I think you kind of touched on my question slightly. So I just wondered, I mean, when you created the blueprint, did you co-create with the very country? So you've obviously looked at what is feasible as someone who's worked in war-torn areas and where there's been floods, earthquakes. Just wondering, have you actually sat down with those very countries to really understand what is feasible in terms of cost, sustainability? Because it's always nice to put a blueprint from afar, but actually working with the people on the ground can change perspective dramatically.
Yeah, I mean, this was the great thing about partnering with Jacobs, because they have infrastructure experience across the world. So we looked at successful projects and what they look like. And from Resolve's side, we've worked across the world. This is start of a conversation for us in terms of engaging with countries and what this looks like. So this is based on best practice from a number of different locations. Urban's going to look different to rural. Even in one country, we spoke to Nigeria, right? PHC is going to look very different in the capital city than it does in conflict-related zones. So the blueprint, there's a document, you know, there's a design in there, but essentially it's the elements of the design that we're bringing to the table rather than a standardized blueprint on how to build a PHC. What we're saying is it needs all of these components, and how we put them together and the principles that we put them together are translatable across countries.
Maybe just to build on what Amanda said, I mean, your comment about have we delivered, we've done a lot of work actually with the nation of Kiribati in the middle of the Pacific, and so a lot of the learnings that we implemented or articulated was certainly relevant from the work we did there. And I talked a little bit about some of the challenges on waste, on medication, on, you talked about autoclaves, some of those real challenges, ventilation and stuff. So they are based on some of our expertise on delivering projects or programs in real locations, but it's not a solution in the context that we expect this to be built per se. These are bringing together some of the concepts and ideas. Can we join them together? And does that, and as I said earlier, it needs to be sort of localized. It does need to be a context specific. So all those things come to play, but it's really trying to provoke a conversation. If we were able to bring these components together, we can start to look at solutions that look at more at a program level. How do we look at a nation, a country, a system, some of those responses? So, I mean, to give you benefit, it's not just made up.
And it shouldn't be the death by paper cut.
No.
We've talked about this. It needs to be a transformational program. Go ahead, Tom. You had
I just want to reflect on some of the things I've been learning from this session and the time that I've spent in PHCs in Africa. A lot of the patients who come in are there for conditions that really could have been prevented. And just thinking about this design as we prototype with partners and think, certainly water, likely electricity, possibly digital access, possibly sanitation, and maybe others. The primary care center could be a catalyst or nidus or place to strengthen this in a broader set of the community that would both help that community in lots of ways and also be really important in preventing people from coming in for the conditions that could have been prevented with safe water or other basic infrastructure. So I hadn't really thought of it until this session, but this concept that not only could the facility be sustainable and resilient, but it could make the community more sustainable and resilient, because what we see in the PHC, in the reality of the day-to-day, is at least some proportion of the patients, maybe more than half, are there for conditions that could have been simply prevented by basic infrastructure that such a facility should create. So it would be really an exponential increase in its impact.
You had a comment I didn't want to miss.
Thank you so much. This is Israel from Ministry of Health, Ethiopia, and I'm leading community engagement and primary health care, as Dr. Mesai said. So I'm interested by seeing these very important and crucial initiatives. So just I want to say something. Currently, as we know, Ethiopia try to expand primary healthcare services, especially hard-to-reach areas, by doing a mapping with a geospatial institute. Coordinate is selected, and those too far from health centers and hospitals are abandoned to get these health services. To reach them, we are trying to design newly initiated design, what we call basic and comprehensive health post designs. And this is much with these initiatives. And we try to, as you said, not only infrastructure, human element is very important to provide the health care for the community. Because of that, they are too far from the towns or cities. No health workforce can get rental house. Because of that, we're thinking about housing of those workforce as well. What is your recommendation for that? It's critical.
It's a really interesting question, actually, because it reminds me, we actually do a lot of work with the Health New Zealand, and they do a similar methodology of prioritization around health investment, that geospatial. How do you look at a population? What are those deprivation index? What are those access points? What are those things? And we've been utilizing that with them to help them inform where their investment prioritization goes. So I was encouraged when you said you were looking at geospatial, and you talked about access to workforce, access to access to facilities and stuff. How can we be smarter about where we spend our investments? Because that decision making, should be based on evidence, science, rational reasoning, not, oh, I'd like one over here and stuff. So I would support your endeavours and the direction, certainly something we've been doing with other nations, and how to help them do that prioritisation.
I think we're almost at time, but one of the things you'll see in the blueprint is staff accommodation. And as a primary nurse, when I worked in an Indigenous community, I got provided housing because there was nowhere to live, and there was no water in the community. And so as a nurse, I got paid extra and given housing to go to those remote areas. So what we're trying to think about, as Dr. Frieden said, is PHC is the center of the community. How do we protect the workforce and make sure that they're comfortable to live there, that they've got access that's safe there, as well as how does the health facility service the rest of the community?
And there are some components that can be transformed into family housing as well, not only the staff housing, as we consider it. Like, as again, to bring all of this together, this is just a suggestion. How do you need to take the multiple components of the design elements and think about which one applies to the local context? In remote areas, again, conflict zones, that would be a different scenario versus like a little more developed environment where you have more people accessing the healthcare, might look differently. However, standardization would bring the cost down. You just need to think about it ahead of time, like I have 10 conflict zones, I have 10 rural access, I have 10 this, and then planning it at scale, and we didn't get to, unfortunately we are running out of time, but I wanted to talk about how do you do it at scale, because that's where the cost savings would come in, because we all know that the resources are limited. But at least we can give you the starting point, and let's now talk about how the starting point can be adjusted at a country level to transform the public health system and primary care system in this case.
Maybe, Nina, just on your comment, we talk around it at system-level programs, looking at the infrastructure at a program approach, so building on that, so rather than it's a one-off solution, how do we look at a programmatic response to delivering primary health care in a location? That may well be another way of delivering efficiencies in cost, in delivery timelines and the likes, and that's something we would certainly consider.
Well, I want to close the session. Thank you so much, Dr. Masai. Landry is not here anymore, but thank you, Amanda and Matthew, and thank you all of our listeners.